Hi everybody, welcome to Dr Manny's YouTube Learn Shops. This is part 2 of Pharmacology for Nurses, which looks at cardiovascular medications, specific cardiovascular medications. Now the learning objectives for this session are to review the autonomic nervous system briefly, look at Beta1 and Beta2 agonists, Alpha1 and Alpha2 agonists, certain antiarrhythmic medications, antihypertensive agents, and then see what you've learnt from this Learn Shop at the end of it. Now, the autonomic nervous system basically consists of two components, the sympathetic and the parasympathetic, or the second sympathetic nervous system. In the sympathetic nervous system, in relation to the cardiovascular system, it increases heart rate through hormones such as epinephrine and norepinephrine and maintains blood pressure. With the parasympathetic nervous system, it inhibits heart rate and causes vasodilation with certain hormones such as acetylcholine. Now, the sympathetic nervous system, through norepinephrine and, as I said, epinephrine, stimulate Beta1 and Beta2 agonists. And this causes an increase in heart rate, which is referred to as chronotropy. It's a positive chronotrope. It increases speed of conduction, which is dromotropy. It increases contractility of the myocardium, which is inotropy, and it causes relaxation of the myocardium thereafter, which is lucidotropy. Now, when it comes to the parasympathetic nervous system, through the vagus nerve and the hormone acetylcholine and muscarinic receptors and nicotinic receptors as well, it has a negative effect on the cardiovascular system, which means it decreases heart rate, chronotropy, decreases speed of conduction, dromotropy, decreases contractility, inotropy, and decreases relaxation, which is lucidotropy. Now, these two systems oppose each other. So the sympathetic nervous system increases, the parasympathetic nervous system decreases. Remember, chronotropy is heart rate. Dromotropy is speed of conduction, inotropy is contractility, and lucidotropy is the degree of relaxation. Now, the sympathetic nervous system is also referred to as the fight or flight system. It's actually our preservation response. So that when you get into a stressful situation of any kind, you activate this system. You either want to fight or you want to run away, flight. And the adrenergic agonists are epinephrine and norepinephrine, and they stimulate the heart rate and they constrict the blood vessels so that the non-vital organs aren't being given blood. In case you want to run away, your muscles need blood, your brain needs to be stimulated with oxygenated blood. The heart pumps blood to your vitalist organs, which are brain, lungs, and your muscles in that situation. When it comes to the parasympathetic nervous system, it's also referred to as the rest and digest system. And in this situation here, as we said, the cholinergic neurotransmitter agonist is acetylcholine, and it slows down the heart rate and it dilates blood vessel. So when you're going to sleep, for example, here, you don't need to have a tachycardia. You don't need to have a bradycardia either. You just need to have a slower heart rate. Now, the cardiovascular medications that we'll sort of be looking at here today are Beta1 and Beta2 agonists, Beta1 and 2 agonist blockers, Alpha1 and Alpha2 agonists, anti-arrhythmic medications, antihypertensive agents, and anti-anginal agents. Now, let's review beta agonists. Beta1 agonists, they're sympathetic, adrenergic Beta1 receptors. And the sympathetic nervous system has adrenergic agonists, which are epinephrine, norepinephrine, and dopamine, naturally occurring. The Beta1 agonists, if stimulated, increase heart rate, speed of conduction, contractility, and the degree of relaxation thereafter. Beta1 receptors. Now, Beta2 agonists have sympathetic adrenergic Beta2 receptors, also stimulated by a sympathetic adrenergic agonist, epinephrine, norepinephrine, and dopamine. Remember, some of you might refer to epinephrine as adrenaline, norepinephrine as noradrenaline, and dopamine remains the same as dopamine. Now with the beta-2 agonists and receptors, these cause bronchodilation, which allows increased air entry. They vasodilate blood vessels to increase tissue perfusion. When we look at the alpha-1 agonists, these are sympathetic nervous system adrenergic alpha-1 receptors that are stimulated. And the sympathetic adrenergic agonists are epinephrine, adrenaline, norepinephrine, noradrenaline. And alpha-1 agonists, if stimulated, vasoconstrict blood vessels to increase and maintain your blood pressure. They may increase or decrease tissue perfusion. It depends on why they were stimulated. They may not. You can have a blood pressure that is considered to be normal and still have all the associated signs of shock, cold, pale, clammy, vasoconstricted limbs. Or by the same token, it can increase your blood pressure and increase tissue perfusion, warm, well-perfused limbs and organs. When it comes to the alpha-2 agonists, the sympathetic adrenergic receptors are alpha-2. Same adrenergic agonists again, epinephrine and norepinephrine, and if alpha-2 receptors are stimulated, they will vasodilate blood vessels to increase or decrease blood pressure. It depends on the clinical situation. If you're in shock, it may not increase. However, it may increase or decrease tissue perfusion. It depends on the clinical circumstances. Now, the adrenergic agonists that we're going to look at are norepinephrine. And norepinephrine, or noradrenaline, is a vasopressor. It's an alpha-1 and alpha-2 agonist, and it elevates your blood pressure. The dose, remember, as with previous situations, the dose depends on your organisation. These are just generic for your information. Typically they're correct, but however you need to review your organisational policy and your pharmacology or your pharmaceutical organisational requirements and policy. The indications for norepinephrine are hypotension, shock situations, low cardiac output with a low systemic vascular resistance. And the major adverse effects will be hypertension, tachycardia, and possibly tissue ischemia if you're using a peripheral vein to infuse this medication. So norepinephrine, epinephrine, and dopamine really should be given via a central vein. Epinephrine is another agonist, and it stimulates alpha-1 and alpha-2, beta-1 and beta-2 receptors. The beta-1 and beta-2 receptors increase heart rate and cause bronchodilation. The alpha-1 and alpha-2 vasoconstrict and vasodilate. Now, the dosage, again dependent on your organisational policy, here is 0.01 to 1 microgram per kg per minute to a maximum dose of 0.1. Pediatric cardiac arrest, 0.01 milligrams per kg. In an adult, 1 milligram. And these are really according to the American Heart Association. But typically, the European Resuscitation Council also recommends them at these doses. Indications are for cardiac arrest, shock, bronchospasm, low cardiac output states with a low systemic vascular resistance, and the major adverse effects are hypertension, tachycardia, and tissue ischemia. Then you have dopamine. Now the action for dopamine is that it stimulates dopaminergic receptors, alpha-1 and beta-1, beta-2 receptors. Beta-1, if stimulated, increase heart rate and contractility. Dopaminergic 1, because there are others as well, increase renal perfusion or glomerular filtration, the glomerular filtration rate. The dosage, typically recommended between 2 and 20 micrograms per kilogram per minute with a maximum dose of 20, but let me tell you, this can vary within organisations and depending on the situation that you are administering this medication. Indications are for bradycardia, cardiogenic shock, and oliguria. The major adverse effects will be hypertension, tachycardia, and cardiac dysrhythmias, such as ventricular tachycardia, possibly ventricular fibrillation, and premature ventricular contractions. Then you have milrinone. Milrinone is a phosphodiesterase inhibitor, and it increases cyclic AMP which increases on contractility. It also vasodilates arteries, therefore decreasing your systemic vascular resistance. The loading dose is typically 50 to 75 milligrams over 10 minutes, and the maintenance is 0.375 to 0.75 milligrams per kilogram per minute. And the indications typically are related to post-cardiac surgery, where the patient has a high systemic vascular resistance, and heart failure states, because it decreases afterload. The major adverse effects can be hypotension because of vasodilation, tachycardia, and cardiac dysrhythmias. Now, the adrenergic agonist receptor blockers are as follows. Remember, an alpha agonist receptor blocker. The purpose is to block the adrenergic drug, which is epinephrine and norepinephrine. So if you look at the diagram, you can see now the alpha adrenergic blocking drug is represented by the cube. Epinephrine and norepinephrine are represented by the sphere. So therefore, the blocking agent blocks epinephrine, adrenaline, or norepinephrine, noradrenaline, from getting to the receptor. And this will have an effect on your epinephrine and norepinephrine outcomes. Phentolamine is the first medication that we'll be looking at. It stimulates as an alpha agonist blocker, and therefore it lowers arterial blood pressure. The dosage typically is 5 to 20 milligrams per dose, whether it's intravenous, intramuscular, or subcutaneous, and the pediatric dose is 0.05 to 0.1 milligrams per kg. But again, this depends on your organisational policy. The indications are if there's been tissue extravasation of something like norepinephrine or epinephrine, even dopamine at a high dose. If you've got autonomic hyperreflexia, which means really a hypertensive crisis, or you've got pheochromocytoma, which again results in a hypertensive crisis. The major adverse effects are hypotension and tachycardia. When you look at beta agonist receptor blockers, you've got cardio and non-cardio selective. And they work primarily the same way as all blocking agents. They inhibit epinephrine and norepinephrine from getting to the receptor site on the cell membrane. Propranolol is the first medication that we'll be looking at. It's a competitive Beta1 and Beta2 antagonist, and therefore it lowers heart rate and arterial blood pressure. It's a beta blocker. The dose, 60 to 120 milligrams. Pediatric, 2 to 4 milligrams per kg per day, maximum 16 milligrams per kg per day. But remember, it's according to your organisational policy. And the indications for this medication are hypertension, tachycardia, cardiac dysrhythmias, and ischemic heart disease. The major adverse effects can be bronchospasm, hypotension, and bradycardia. So this medication is not recommended for people with chronic lung disease, such as asthmatics, because it's a beta-2 antagonist, which means it will cause bronchospasm through bronchoconstriction. Not recommended. Do not take Indirel, which is the trade name for propranolol, if you have a history of asthma or wheezing, meaning breathing difficulties. Atenolol is a selective beta-1 blocker, and it also lowers heart rate and arterial blood pressure. The dose depends on your organisational policy, but here 50 to 100 milligrams. The indications are hypertension, tachycardia, dysrhythmias, ischemic heart disease with chronic lung disease, because it doesn't block beta-2 receptors. Therefore, it won't cause bronchoconstriction, it won't cause breathing difficulties. The major effects will be, however, or could be, hypotension and bradycardia. Now let's review antiarrhythmics as receptor blockers. But remember, we've only covered some of the beta blockers. There are many, many, many more. When it comes to antiarrhythmics, they're classified according to which part of the cell membrane is affected. or where the action potential is affected. When we look at class 1 sodium channel blockers, they block phase 0 to 1 of the action potential. And this is related to sodium and chloride entry. And typically it lasts for about 3 to 5 milliseconds, ending with closure of the voltage or fast sodium channels. When we look at sodium channel blockers, which shorten phase 0 to phase 1, which is ventricular depolarization time, we have 3 classes. Class 1A, 1B, 1C. I'm only going to be reviewing class 1B because they're the most common. You can review the others, class 1A and 1C, at your leisure in other Learn shops. Or you can advise me that you would want an extension to this Learn shop. Now, class 1A sodium channel blockers consist of quinidine, procainamide and disopyramide, and essentially they block sodium inflow, which slows phase 0, which is depolarization. Class 1B, lidocaine or lignocaine, mexiletine, phenytoin or tacainide, shorten phase 0 of depolarization, which is also affecting sodium inflow. It's blocking sodium channels. Class 1C, flecainide and propafenone, markedly slows phase 0, which is also depolarization, and it blocks sodium inflow. It depends on the cardiac dysrhythmia as to which class or sodium channel blocker that your cardiologist would recommend. We're going to focus on, as I said, class 1B, sodium inflow block, which basically shortens, not slows, not markedly slows, just shortens phase 0 of depolarization. And we're going to be looking at primarily lidocaine or lignocaine. Now, lidocaine is a cell membrane sodium channel blocker. Loading dose is typically 75 to 100 milligrams over 2 minutes, or 1 to 1.5 milligrams per kg. But remember, as I've repeated constantly, this depends on your organizational policy. These are just generic doses that you can consider, or refer to your pharmacology department. After that, you can repeat it within 30 minutes and you give a half dose, 0.5 to 0.75 milligrams per kg, maintenance infusion 2 to 4 milligrams per minute for about 24 to 30 hours. And the indications are really for ventricular arrhythmias or dysrhythmias such as ventricular tachycardia or ventricular fibrillation. That's refractory to other forms of treatment. The major adverse effects are central nervous system visual effects, finger tingling or numbness, confusion, in the worst possible scenario, tonic-clonic seizures. Now here's an example. You've got before the lidocaine, this person was in coarse ventricular fibrillation. After lidocaine, God willing, they converted back into sinus rhythm. But it doesn't always go like that. This is the ideal situation. Now let's review class 2, which are beta channel blockers. And these prolong phase 4 of the SA node in their action potential. And basically what they're doing is blocking epinephrine, adrenaline, norepinephrine, noradrenaline, and they're blocking the calcium inflow channels. As you can see in the graph, phase 4. And this is where the SA node is typically depolarized. Now, propranolol is a good medication. It's a cell membrane beta channel blocker. And the doses we mentioned previously is 1 milligram per dose over 2 minutes, maximum 5 milligrams. Pediatric will be lower, but again, refer to your organizational policy. Indications are for sinus tachycardia, but sinus tachycardia is normal. We're talking about compromising sinus tachycardias. So if you have a tachycardia that is fast and it's sinus and they've got hemodynamic effects, which means they're demonstrating signs of shock, then this could be indicated. It's also for hypertension and supraventricular arrhythmias, such as atrial tachycardia, rapid atrial fibrillation, maybe atrial flutter, but it depends on your cardiologist. The major adverse effects are bradycardia, hypotension, and bronchospasm, because as we said, propranolol is not recommended for people with chronic lung disease, such as asthma or having wheezing or breathing difficulties. Now have a look. This is a supraventricular tachycardia before the propranolol, and God willing again, after the propranolol, they've converted to a sinus rhythm. Class 3 are potassium channel blockers. Now they slow or block phase 3 of the action potential, indicated there. Amiodarone is actually a class 1, class 2, class 3 and class 4, but specifically it's class 3, a potassium channel blocker. And it's a very, very potent medication. And because it's so potent, it can have major side effects as well. Now the dosage depends. However, typically 150 milligrams over 10 minutes, then continued with 360 milligrams over 6 hours, at 60 milligrams per hour. This is an infusion. Then 540 milligrams over 18 hours, which is 30 milligrams per hour. In cardiac arrest situations, it's 300 milligrams stat. In pediatrics, you can see what the dose is, but remember, it's according to your organisational policy. These are recommendations from the American Heart Association. The indications are for both atrial and ventricular arrhythmias, which indicates that it is a class 1, 2, 3 and 4 channel blocker, but specifically here we're looking at as a class 3 potassium channel blocker. Major adverse effects are lengthening of the QT interval, which can promote a lethal dysrhythmia such as torsades de pointe, which is a form of polymorphic ventricular tachycardia. Have a look. Here we've got monomorphic ventricular tachycardia before the amiodarone. It didn't seem to respond to anything. And this is probably going to be with a patient that has a pulse. So this is ventricular tachycardia with a pulse, but it could be given for pulsus ventricular tachycardia as well. After the amiodarone, fantastic, the patient has converted into a sinus rhythm. The last group are class 4, calcium channel blockers, and they slow or block phase 2 of the action potential. As is indicated here, in phase 2, this is to do with calcium entry, so it blocks calcium entry. Verapamil was probably one of the first calcium channel blockers, and it works both on cardiac and smooth muscle, so it slows conduction through the atrioventricular node. The dose is typically intravenously 2.5 to 5 milligrams, with a second dose higher, 5 to 10 milligrams, if the patient can tolerate it. And it's for the treatment of supraventricular tachycardia. However, it has been superseded by adenosine, which we'll be reviewing shortly. However, if you do give verapamil, it's used for supraventricular arrhythmias such as atrial tachycardias, atrial fibrillation, atrial flutter. The major effects or adverse effects are hypotension and bradycardia. Have a look. Before verapamil, we have a supraventricular tachycardia. After verapamil, God willing, they have converted into a sinus rhythm. Now, class 4A calcium channel blockers block or slow phase 2 of the action potential. Same as what we saw with class 4, but this is adenosine, which is a variant. Now, adenosine opens potassium channels and it inhibits calcium channels. In an adult, the maximum intravenous dose is 6 milligrams. It's repeated if there are no adverse effects within 1 to 2 minutes. So you can give a maximum dose of 12 milligrams. In the pediatrics, 0.1 milligrams per kg, maximum dose 6 milligrams, the same as an adult. And if there are nil effects being, if they don't go into asystole, then within 1 to 2 minutes you can repeat the dose. But again, maximum dose 12 milligrams. The indications are for AV nodal reentry tachycardia, paroxysmal supraventricular tachycardia, any supraventricular tachycardia that probably doesn't respond to vagal or Valsalva maneuvers or other medications or other interventions. The major adverse effects are hypotension, bradycardia, and in the worst scenario, asystole. Have a look. Before adenosine, you've got a supraventricular tachycardia that's approximately 160 beats per minute. After adenosine, into sinus rhythm at about 75 beats per minute. Now let's review some of the antihypertensive agents, and these are vasodilators and venodilators. And I've only chosen a few. You can review others as well. But sodium nitroprusside is fairly well known. Its action is as an arterial and a venous smooth muscle dilator. It causes vasodilation, arterioles, venodilation, venules. The dose, again according to your organisational policy, but the generic dose here, intravenously 1 to 4 micrograms per kilogram, maximum 10 micrograms per kilogram per minute as an infusion. Or you can use a weight formula, 6 milligrams by weight, kg, added to the total volume, 100 mils, 5% dextrose, 1 mil per hour, which equals 1 microgram per kilogram per minute. Indications are for any form of hypertensive crisis, pulmonary hypertension. The major effects, however, are hypotension. The major adverse effects are hypotension. Then you've got glycerol trinitrate, nitroglycerin. And the action is primarily as a venous smooth muscle dilator. It causes venodilation. The adult dose, you can either give it sublingually, or you can give it as a spray, you can give it as a tablet, you can give it intravenously. However, follow your organisational policy. Indications typically would be for angina, acute myocardial infarction, associated with acute pulmonary edema, having pulmonary hypertension, or post-coronary artery bypass graft surgery, where you want to decrease afterload or decrease preload, or dilate the venous grafts which have been transplanted. The major adverse effects are hypotension and tachycardia, so you err on the side of caution. Then you've got sildenafil, Viagra. Now I'm not going to go into what the real reason for Viagra is for, but in a cardiac situation, the action is as a phosphodiesterase enzyme receptor blocker. It causes smooth muscle relaxation, which is veins. The adult dose typically is 25 to 100 milligrams daily. The pediatric dose, which can be used for patients with heart failure, yes, even pediatric patients have heart failure and can be on Viagra, but this has to be ordered by a pediatrician, and it follows your organisational policy. The indications are pulmonary hypertension, and as I said, congestive heart failure, or heart failure related to any cardiac situation, depending on what the cardiologist believes is appropriate. The major adverse effects can be hypotension. Okay, before we end this learn shop, let's review some of the information from the previous introductory workshop. Name the 5 components that relate to pharmacokinetics. Well, pharmacokinetics relates to absorption, distribution, bioavailability, metabolism, and elimination. Name the organ which creates a large first pass effect. Well, that organ is the liver, and it has a large removal effect on oral medications because they go to the liver. Some are eliminated, some are neutralized immediately. Many require an alternate route, such as, for example, insulin. If insulin is taken orally, the first pass effect will destroy it immediately, so therefore it's given subcutaneously, intramuscularly, not recommended typically, or intravenously. Name 5 medication administration rights. And these are really important, as you are aware. The first one is the right patient. Full name and medical record number. Second right, right prescribed medication. Generic name is preferred, written clearly and correctly by the prescribing physician. Third right, right prescribed medication dose, no abbreviations, written clearly and correctly by the prescribing physician. Fourth right, right prescribed medication route, no abbreviations, written clearly and correctly. Fifth right, right prescribed medication date and time, no abbreviations, written clearly and correctly. Activity 4. Name 3 high alert medications. You can name more if you want to, but 3 is all I'm asking for. Warfarin, morphine, fentanyl, insulin, heparin. Okay, thanks. That concludes this Learn Shop. Now, if you found this of any benefit to you, please recommend it to your colleagues, your friends, subscribe to me if you wish to, and then go to part 3, because there's part 3, 4, 5, 6, 7, 8 of this Pharmacology Learn Shop on YouTube. Thanks. See you next time.